Hi, this is Huey Lin. Thanks for joining me. This is going to be a case review and a brief literature review on balloon pulmonary angioplasty and CTEPH. This was originally given as part of an internal medicine grand rounds here at UCSF, November 19th, 2024. So my disclosures at present are that I'm a proctor for Abbott and Gore, and really I learned everything about balloon pulmonary angioplasty from Drs. Hiromi Matsubara and Zach Steinberg. So during this brief talk, I'll be explaining some of the anatomical issues important for CTEPH balloon pulmonary angioplasty. We'll talk a little bit about the risk of complications in balloon pulmonary angioplasty, and then talk about the impact of balloon pulmonary angioplasty lesion type on hemodynamics. So let's go ahead and start off with the case. This is a 32-year-old woman with dyspnea on exertion. She presented, like many of our patients, with swelling and subsequently was found to have multiple presentations for pulmonary embolism, or what was thought to be that. She was also found to have antiphospholipid antibody syndrome, and her initial echo showed an RVSP of approximately 60 millimeters of mercury, suggesting pulmonary hypertension. This, of course, is her lung perfusion scan. You can see that classic moth-eaten appearance of reduced perfusion in multiple different segments and subsegments of both lungs. And of course, now we're finding this modern technology of dual energy CT really allows us to get a better and finer distinction of where those perfusion defects are relative to the anatomical pulmonary arterial anatomy. And this is the type of reconstruction that we can do that really helps us to hone in on our treatment strategies. So we take her to the cath lab, and this is initially her left pulmonary angiogram. And as Dr. Billiger always likes to say, on the left we see the AP view, which gives you a really nice gestalt view of the reduction in perfusion in the different areas of our lung. But really the anatomical data comes on the right, which is the lateral view. And you can see on the right with the lateral view that there are really multiple segments that are reduced in terms of perfusion. And if you look carefully, you can see that there are multiple areas of occlusion and subtotally occluded segments. Then when we look at the right pulmonary artery, again, on the left side of the screen, you see the AP view, which really gives you a sense of multiple areas of reduced perfusion. And anatomically, on the right side of the screen, you see the lateral view, which actually shows you that the entire lower lobe is absent in terms of perfusion. So there's a chronic occlusion there. So this was done via access to the radial artery and right internal jugular vein. We found that her fit cardiac output was 4.3 liters per minute, and her thermodilution was 6.1 liters per minute, which obviously we often see potentially an issue when there's some degree of tricuspid regurgitation. Her baseline hemodynamics suggested that her mean right atrial pressure was 7. Her RV pressure and PA pressure were in the mid-50s with a mean PA pressure of 32, a wedge pressure of 14, and an LV end diastolic pressure that mimics her wedge pressure at 14, and an arterial pressure with mean arterial pressure of 69. Pulmonary vascular resistance calculated from this was approximately 4.2 Woods units, and our SVR 14 Woods units. And as we do in many of our patients who are considering for thromboendarterectomy surgery, she also had coronary angiography and was found to have normal coronary arteries, as we would expect in this young woman. So what would we do next at this point in time? And what do we know about balloon pulmonary angioplasty and its outcomes? So the first landmark study that we're going to talk about is this study here. And this came from Boston Children's Hospital, because who else gets peripheral pulmonary arterial lesions? Turns out that congenital heart patients are vulnerable to this. And so this was done from Jonathan Feinstein with Mike Landsberg and their group. And these were really the first reported balloon pulmonary angioplasty treatments for chronic thromboembolic pulmonary hypertension. And I think this is a very brave group of cases and operators, because within those 18 cases, they had a number of complications. One who actually had pulmonary arterial rupture, and that was treated with a coil. And multiple patients who ended up having pulmonary edema, and then one actual death. And so thankfully, we didn't stop with this. The field continued working off of this initial success, if you will. So that brings us to landmark study 2. And this at the time was the largest accumulation from a single center of balloon pulmonary angioplasty, led by Dr. Hiromi Matsubara and his group. As you can see here, published in 2016. And this is what really helped us to understand what does this treatment look like when we look at it on a large scale, and how do we categorize the lesions that we approach. So this is 500 procedures and 1,936 lesions that were treated. So when we look at this large scale, what were the complications that they reported in 97 patients? Well, they were able to reduce the mean pulmonary arterial pressure pretty substantially But there were 19.6% episodes of hemoptysis, almost 20% in almost 98 procedures, almost 100 procedures. There was evidence of pulmonary arterial injury after balloon pulmonary angioplasty, including hypoxia, radiographic opacities in approximately 26% of the procedures. In 55 patients, this was really just mild. In 10, it was actually severe, requiring intubation and mechanical ventilation, and 7 went on to require ECMO. And from this, 4 patients died in hospital. So 4 deaths out of 97 patients treated. But this was really probably one of the most aggressive and successful reports on a large scale of balloon pulmonary angioplasty and CTEPH, with a reduction from a mean PA pressure of approximately 45 down to 23.3, so almost halving the initial mean PA pressures, and a subsequent reduction in resting right atrial pressure, as well as an increase in cardiac index and a complete decrease in pulmonary vascular resistance. So really, all told, leading to a lot of optimism and a pathway towards success as another method for treating CTEPH. And what they showed us was that really this is kind of what we're seeing when we do balloon pulmonary angioplasty. This is from another report looking at what actually occurs after balloon pulmonary angioplasty. You can see a dissection. Ultimately, what's quite incredible is after that initial dissection that's created by the balloon pulmonary angioplasty, subsequently the vessel heals spontaneously, and there's an increase in the size of the lumen of the vessel, and subsequently reduction in pulmonary vascular resistance with this. So we learned a lot from these initial series. And that brings us to landmark study number 3, which is from my good friend, Dr. Zach Steinberg. And this was approaching a balloon pulmonary angioplasty in a much more aggressive manner, because as we found as we started doing balloon pulmonary angioplasty, a lot of these lesions are actually chronically total occlusions. So what that means is that we have to take a much more aggressive approach. And so what Zach reported in this study was what actually happens in terms of complications when you take a very aggressive approach. And the key piece to this was he used CTO techniques from the coronary space, which includes using a microcatheter once you've actually punctured through the chronic total occlusion cap. And what you're seeing here is what happens when you puncture into a space that is not your target. So in A, you see the pulmonary vein light up. In B, you see an alveolus light up. In C, you see a bronchus light up. And in D, you see the pleural space light up. And we're getting these images as the operator injected contrast to the microcatheter once they had gone extravascular. So what happens when you do this? Well, it turns out that in 21 cases, there were a number of successes after multiple attempts at CTO recanalization, and you can see here what actually happened from wire perforation, dissection, etc. And so in the far right-hand segment, you can see what they actually did. So in 14 out of 15 cases, they didn't have to actually do anything. And in 1 out of the 15 cases, they had to terminate the procedure early, and the patient had prolonged hospitalization. So in reality, a lot of these patients could actually be treated conservatively, despite the fact that there was a perforation with the wire and a microcatheter into an extravascular space, which suggests that we can be a lot more aggressive in our approach for balloon pulmonary angioplasty and CTEPH, using carefully and well thought out meticulous CTO techniques. And that leads us to landmark study number 4 by Irene Lang's group. And this now is one of the largest accumulations of a single center experience in balloon pulmonary angioplasty. And they went on to look at, if you take on subtotal and chronic total occlusions in balloon pulmonary angioplasty, what is the impact of that on the hemodynamics? And this is their nice graphical abstract. So what you're seeing here is in the far right-hand side of this figure, the reduction in mean pulmonary arterial pressure by percentage. So it's about 0.8% reduction, with approaching just lesions that are non-occlusive, so stenoses as opposed to complete occlusions or subtotal occlusions. On the other hand, if you approach true subtotal and chronically total occlusions per vessel, you see approximately a 2% reduction in mean pulmonary arterial pressure, suggesting that truly the bang for the buck is going after these subtotal and chronic total occlusions, paving the way to applying a lot of these techniques that Dr. Steinberg presented to us in the previous landmark study. So what were they able to show us? So after complete balloon pulmonary angioplasty in approximately 45 patients, as you see here, defined as a significant reduction in mean pulmonary arterial pressure with certain goals, you can see that they truly were able to reduce their mean pulmonary arterial pressure from approximately 39 millimeters of mercury down to approximately 25.5 millimeters of mercury, with a substantial reduction, almost halving of the pulmonary vascular resistance. That said, no surprise, there was some degree of complications. So when they looked at all patients that they treated, 120 of them, there were 13 episodes of hemoptysis, approximately 11% of cases, and pulmonary injury, approximately 12%, ranging from 9% mild and 2.5% severe. That said, some of those did go on to mechanical ventilation and ECMO. And what you are all probably wondering at this point in time is, when you are this aggressive with your intervention in balloon pulmonary angioplasty, what is the death rate? So it turns out that there are 3 procedural deaths, 2 of the pulmonary injuries, as we reported earlier, leading to ECMO and subsequent expiration of the patient, and 1 patient who actually had a vagal event and could not be resuscitated. Just going back to really how sick these pulmonary hypertension patients are with their CTEPH, and that at the end of the day, they do need to be treated with meticulous care. So ultimately, I think the take-home point from this is that aggressive balloon pulmonary angioplasty in CTEPH can be moderate to high risk, but also very high reward in chronic normal balloon pulmonary hypertension. I think we've learned a lot from these 4 landmark studies. So going back to our case, what I'm showing here is a slideshow showing through all of the serial balloon pulmonary angioplasty sessions that we completed in our patient. And then on the bottom left-hand side of the screen, you can see our initial hemodynamics, and I want to really highlight in yellow the post-serial balloon pulmonary angioplasty hemodynamics is approximately 10 sessions. So what you can see here is we were able to increase our FIC cardiac output from 4.3 to 6.3, really normalizing her cardiac index. And if you look at the mean pulmonary arterial pressure, it was able to be reduced from 32 millimeters of mercury down to 21 millimeters of mercury. And her pulmonary vascular resistance nearly normalized from 4.2 Woods units down to 1.4 Woods units. And so I think this is just further evidence that the data that's been published by other very successful operators can be applied to our patients as well. And sort of going back to this initial theme of CTO, you can see here that the superior segmental, or A6 branch in the left pulmonary artery is completely occluded in this patient that we just presented. And so we brought her back for recanalization of the CTO, hardened by the data that we saw. And so what we did was, because we'd actually been unsuccessful previously in recanalizing this, we brought on some additional technology, including this rotational angiography on the table, and then the subsequent reconstruction of the data, and using that 3D reconstruction to build the pathway of the vessel, because that can't be visualized angiographically. And then we use this to identify optimal viewing angles and the pathway to which we were going to have to cross. And here you can see subsequently we're able to cross through the chronic total occlusion and balloon it up. And you can see that we're now developing a reasonably large size territory that correlates with that superior segmental area of the left pulmonary artery. So in summary, what we've discussed today is that the anatomy and the lesion type in CTEPH and the balloon pulmonary angioplasty results that can come from approaching these chronic occlusions, subtotal occlusions, can have an impact on the outcome and the hemodynamic outcome in these patients. But likewise, we do have to prepare for complications, because after all, this is a moderate to high risk procedure, especially when we start approaching chronic and subtotal occlusions. But these risks can potentially be mitigated. And at the end of the day, these moderate risks are resulting in high rewards with significant hemodynamic and quality of life improvement in these patients. I do want to again plug the mentors that have helped us get to this point in terms of our balloon pulmonary angioplasty: Dr. Hiromi Matsubara and his fantastic team at Okayama Medical Center, of course, Dr. Zach Steinberg at the University of Washington in Seattle. And finally, I would be remiss if I did not congratulate the fantastic team at UCSF on their first balloon pulmonary angioplasties last week. led by Dr. Miles Conrad, Dr. Pete Luck, and Dr. Christian Soni, and this fantastic team. They accomplished some incredible work on 2 patients with chronic thromboembolic pulmonary hypertension.